Hey, what's going on, guys? Paul Kellogg here. Uh, Research topic: HIV/AIDS in Kenya and model implementation to help prevent its spread. I'll be doing my presentation now over the things that I outlined in my research paper regarding this topic here. And we'll go ahead and we'll start with the review of my global health target population. My target health population that was addressed in the paper was the actual inhabitants of the country of Kenya. Basically, the individuals who are affected by HIV/AIDS and the steps that could be taken to prevent its spread, not only by the individuals that have it, but how do we protect the individuals that don't have it with education, with preventative measures, with medical, uh, science and breakthroughs that we could utilize to help protect those individuals. The estimates that the government of Kenya AIDS Control Unit, Census Bureau, the data that they collected in the early 1990s said that about 500,000 people were living with HIV/AIDS, and by 2000 the number had increased to over 2 million people. So we're looking at roughly a 250% increase in just a decade's worth of time. Obviously, if that continues to happen, we're looking at a pretty substantial growth of HIV and AIDS just in this country alone, not on the continent, but just in this country alone. And if one of the better developed countries are having this type of rapid expansion with this virus, that doesn't bode very well for other countries, given the fact that Kenya actually is one of the more successful economic strongholds within that region. Some fast facts about that target population. In regards to their ability to generate income necessary to combat HIV/AIDS, the total that they spent domestically in 2000, the country of Kenya, was vastly below the almost $580 million today that they're able to bring in from the international community to help. In 2000, the percentage of children aged 15 to 49 that had HIV/AIDS was 10.8%, and today that number stands at 6%. So you can see that by having that expansive economy, they were able to utilize the funds that they were bringing in by growing as a country to help combat some of the spread of AIDS, but there were still different steps and measures that I believe could have been done differently to make this number even smaller than where it's at. And in that same time span, in the 2000s, the GDP of the country of Kenya was able to grow by almost 5 times, from a little over 12.5 billion to its pinnacle now at 55 billion. So we do see some pretty good growth within the country. And when the growth economically happens, then we have means and ways to be able to afford the education, the medicine, and basically anything that we could use or classify as a preventative measure to help combat the spread of HIV/AIDS here. The disparities that are partially to blame for the virus's ability to spread so rampantly is that of the education levels, the economy, the accessibility to doctors and medical treatments, the amount of money that preventative measures cost to combat the possibility of contracting such a deadly disease. Initially, women's disproportionate vulnerability is explained in this paper as resulting from their economic reliance on men. It makes women prone to coercion and place them in a position requiring basically an exchange for sex, for money or housing. So we see basically one part of the population that's just having to have sex as a means of survival, and individuals that are basically using them to get whatever sort of pleasure they need out of it. But that's one of the reasons that the virus can spread so rampantly like this. It's basically what you could call survival sex, is what I listed it in the paper as. These women are just having to do it so they can have the money and the means to provide for themselves and their family. And when it gets to a point such as this, desperate times, desperate measures, I would imagine. The disparities in social determinants and vulnerabilities continued. A lot of the research demonstrated that many sexual relationships contain a transactional element, something that I just spoke on now. And even when not explicitly a commercial activity, these types of sexual relationships still place women at a risk for HIV. So we're not looking at just a woman who's getting HIV. We're looking at her possible offspring also having it too. So that's obviously not a good mix when we're trying to figure out how to combat the spread of this. In a society such as this that does not expand its economy to its population in the form of adequate work or the ability to find jobs, yes, we did see economic expansion within the country of Kenya, but for some reason that didn't equivocate to equality in the workforce or being able to find jobs. And that is outlined in the paper. Basically, you see that expansion within the economy, but you don't see that expansion within the workforce either. You still see these individuals having to rely on sexual activity for money to basically provide for themselves and for their families. And some of the stigma and stressors that go along with it basically are those jobs, those situations that place people in dangerous situations to be exposed to HIV. Stigma and discrimination has a possible outcome to affect the well-being, socioeconomic, and emotional stability of people that have HIV/AIDS that are receiving help from a health provider to effectively deliver care and treatment in regards to prevention. To continue on with those stigma and stressors, it's been shown to deter pregnant women from accepting HIV testing in Kenya. A priority going forward, thus, has been to develop interventions that can effectively reduce stigma in communities affected by HIV/AIDS. So we need to now empower women to basically not feel like because we want to test them for HIV/AIDS that they may have it or it's a negative reasoning behind taking the test. One step that will be mentioned in my outline is the fact that we need to make these tests more understandable to the people taking them, that it's for their own health and benefit and not sort of a negative connotation that since you're taking the test, there's something negative behind it. My model and assessment framework would basically fall within basically putting it on the decision maker. For mine, that would be the health belief model. That model suggests that decision makers make a mental calculus about whether the benefits of a promoted behavior change outweigh its practical and psychological costs or obstacles. Basically saying individuals conduct an internal assessment of the net benefits in changing their way of life, their behavior, and do I want to do this or not? We need to make it more known to them that taking these tests and putting themselves in a better position to be successful as to not be exposed to the spread of HIV/AIDS is actually a good thing. And one example of this would be to promote safe sex and to bring awareness to the danger of sleeping with a partner that may not know they are currently a carrier of the disease. Sexual risk factors also include having multiple sex partners and being infected with other STDs at the same time. And we see that in this study here, heterosexual contact is the primary mode of HIV transmission. To continue on with that model and assessment framework, when applied to HIV sexual risk behavior, this health belief model suggests that simple knowledge and awareness about HIV will not necessarily result in the reduce of risky behavior, but what I can do with this is basically put it in their hands to take charge of themselves. Perceived susceptibility, perceived severity, perceived benefits, those are thought to be positively related to HIV/AIDS preventative behavior and barriers to taking action, even though they are thought to be negatively related to it, such as condoms and abstinence. The Kleinman-Benson Approach program, the awareness program will have individuals state exactly who they are by cultural beliefs, location, and things like they could do to basically things that they could say, hey, what would you be afraid to lose if you contracted the virus? So being able to ask those questions, being able to understand your population is basically what's going to help you determine how to properly approach the steps that will follow as to not only respect their way of life, but also to understand the stigma, the stressors, and everything else associated with their reasoning, whether they basically give a damn or not about contracting HIV/AIDS. My program implementation would basically be to connect Kenya to hardwired internet. Connecting these people would have the ability to start a campaign using a platform that can reach millions instantly with the information necessary to combat the spread of HIV/AIDS. In 2012, the people in Kenya that were using Facebook was approaching 2 million people in a country more of 40 million. And we see that as the infrastructure grows, as the economy grows, we're seeing an expansion of being able to provide this hardwired internet. And if we can put this hardwired internet not only in cafes and in homes, but in schools, the education value that we could utilize to spread across an expansive network would help educate these people a lot faster. By using that approach for different areas in Kenya, we can determine the best way to do our community-based testing. What do we do to basically put these cultural groups and religious groups that are spread all over the region, and how do we get them basically on the same page when it comes to community-based testing? We can also learn a lot of valuable data. How do we respect the patient? How do we reduce the stigma of testing everything altogether? So basically that program implementation of connecting, basically by connecting Kenya, by education in terms of sexual abstinence, condoms, basically those three things that we could utilize, putting them in better situations, teaching them better situations in regards to their sexual activity, connecting them across a very expansive network so there is education, there is communication, and then we basically turn that into finding ways and alternative means to getting people in community-based testing, because if we can reduce that stigma of individuals who think just taking the test is negative in itself, then we've already lost. We need to make people want to take these tests, and I think that by connecting them and by educating them is the best possible way to continue on to that community-based testing. So the references that you see now were utilized in the creation of this presentation. I appreciate your time, and I look forward to your feedback.